Good morning. My name is Adam Gibson, and on behalf of Texas Children's Hospital, I'm pleased to welcome you all to our plenary session, Strengthening Public Health and Surgical Care in LMICs. Our moderator today is Dr. Girma Tefera, who is Medical Director of Operation Giving Back from the American College of Surgeons. Dr. Tefera is a vascular surgeon and a professor of surgery at the Department of Surgery at the University of Wisconsin. He is also Vice Chair of the Division of Vascular Surgery and Chief of Vascular Surgery at Memorial Veterans Hospital in Madison. Dr. Tefera specializes in minimally invasive vascular interventions, including stents, grafts for complex aortic aneurysm treatment, as well as percutaneous treatments of carotid arteries and vascular diseases of the lower extremity. Dr. Tefera joined the American College of Surgeons Division of Member Services as the Medical Director of Operation Giving Back, which is a comprehensive resource that helps surgeons find volunteer opportunities worldwide that match their experience and interest. Dr. Tefera attended the University of Pisa Medical School in Italy. He completed a surgical residency in Dresden, Germany, and he also completed a surgical residency at Howard University Hospital in Washington, DC. We're pleased to have you, Dr. Tefera, today to kick us off and share this wonderful panel with everyone.
Thank you, Adam. And I really want to thank the Texas Children's Hospital for organizing this outstanding panel that we have today. And this panel has presenters and speakers from different continents as well as different specialties. So I think the audience will really enjoy and will share with you amazing experiences they have in doing global health work in general, so that I think the next generation of our global health workers in general will benefit from this, learning both from the challenges that our presenters will share with you, as well as the good results that they have, as well as maybe some of the failures or challenges they have encountered. So with that, I would also want to encourage everyone in the audience to really go into the Q&A sessions to put in their questions. And if you have a problem putting in the Q&A, I'll try to check also the chat session, but the Q&A will be really the best place to have your questions. And we will get back to your questions at the end of the presentations where we will have all the panels together. We have two slide presentations and two video presentations, and at the end we'll have somewhere around 15 minutes of Q&A sessions. So without any further delay, the first presenter is Professor Kokila Lakhoo from the United Kingdom. She's a professor in pediatric surgery. She's a consultant at Oxford Hospital, Children's Hospital in Oxford. She is trained in South Africa, however, practices and leads pediatric surgery in the UK, and she has been very much involved in developing pediatric surgery, particularly in Tanzania, but her role and engagement has been much wider than that. She has been actually one of the presidents from Global Initiative for Children's Surgery, organized an organization that has been present for a few years now, and she has followed also works within the Lancet Commission. She is well versed in global health and global surgery, and her experience actually that she's going to share with us will definitely shed a lot of light of many years of hard work she had in Tanzania. So without any delay, Kokila, the mic is yours. Thank you.
Thank you very much for that kind introduction. I'll just get my slides on the roll. I'm most indebted to the Texas Children's Hospital for inviting me. I thought this weekend I was going to be in Texas, but no, I'm here in Oxford and still sharing a platform with all of you. So without much ado, I'll start off with what global surgery means to all of us. Now, working towards equity in surgery worldwide is our motto in the Global Initiative for Children's Surgery, which you heard about, as well as our Oxford University Global Surgery Group, which is made up of 4 departments, the obstetrics department, the surgical department, the orthopedic musculoskeletal department, and anesthesia. I always kind of battled with trying to understand what does global surgery actually mean and how do you define it? And in 2019, there was an article in the British Journal of Surgery, which eloquently put it as actually public health in surgery. And I thought that was very well said. However, it's quite important to listen to what our lower income country colleagues have to say with our involvement. And I think we have to take heed of this and understand this. Otherwise, whatever we're trying to do or whatever we're trying to collaborate with will not work if there's no engagement from the ground. So my invitation for today's talk was my experience in capacity building in global surgery in Tanzania. I started 20 years ago when an invitation came across to me to develop pediatric surgery in Tanzania, where most patients were being sent abroad to have their treatment or would never get any treatment. And I thought about it and did a site visit and unfunded with 2 weeks of my annual leave, I started the project where the capacity building didn't come from me, but the capacity building came from within. All I did was catalyze the program. So we started off with having chats and discussions with trained general surgeons to take on interest in pediatric surgery. And in the first 2 years, there were 2 people interested. We created a liaison between pediatricians and surgeons so that children that were 6 months and 3 months old were not in the adult ward. We created a workspace, we created nursing liaison, and it was just with no extra cost, but just changing the system around, using the capacity that was there, getting trainees interested. We carried on for year by year, developing pediatric surgery and improving and extending the work to other centers. So if you look at the slide, you can see all the work that has been done over 20 years, whereby there are now 12 trained pediatric surgeons. There are now 4 pediatric surgery centers. And the most recent one is in the northern part of Tanzania. But the training and development has been done internally with no external person coming to support the startup surgeon in the northern part. We have support from Kids OR for theaters. And parallel to that, we did presentations. We brought in academia. We brought in training and development, which is now all established. And the only thing that I'm at presently funding is a researcher to take up now funded research projects jointly with Oxford University and the Muhimbili University in Tanzania. I was asked to say, in this process of capacity building, what were the failures? So in the 4th year of the program, and as I said, it was just 2 years per year in my annual leave. And at that time, my children were 18 months and 4 years old. So it was a trying time and I needed a lot of family support. And it would have never happened if we, as a family, my husband and myself, didn't work this together to make it happen. So the first difficulty that came about was 4 years in the program when arriving there, the 2 trained surgeons were sent to other centers by the government because in Tanzania, the government dictates where you train and where you work. The second failure was once I got there and realized that the 2 trained surgeons weren't there, we just carried on with the other surgical team that were present and didn't flinch about that issue. The second problem was an external one where HIV programs started establishing in different parts of Africa. and they put up a huge HIV center on the ground and depleted the entire hospital of their staff. And that needed to be rebranded back into the hospital by having a very visionary medical director who then realized what was going on and devised a program to let the HIV program happen, but not deplete the hospital. I mean, it is quite scandalous that it was huge Bill Gates funding and the hospital didn't have a single computer for its function. The other challenge that took place is the medical director changed at year 8 of the program, and all support to collaborators was stopped. And I was just lucky, I don't know why, but just I was allowed to continue, and a ophthalmology team was allowed to continue. So those are some of the challenges that I experienced. And what I have to say is that where there's a will, there's a way. And I think giving up with these challenges would not make a program work. And I just want to complete my talk by saying a little story whereby an anthropologist from the UK visited a village in Africa wanting to study the behavior of children. He put a bowl of fruit under a tree, lined all the children up of any size, age, and said, right, the one who can run the fastest can have the fruit and enjoy it. And what the children did is at the start of the whistle, they all held hands and walked and partly ran to the fruit and shared it. And he was quite confused at this behavior. And the oldest child said that in our culture, we believe in working together. We believe that I am because we are, otherwise nothing would work. Thank you very much for your time.
Thank you so much for this outstanding and inspiring talk. And I think we will come to questions and answers later. So we'll have the next presentation, which is going to be a pre-recorded video presentation. However, our speaker is actually going to be in the panel so that she will be able to answer the questions. The presentation is in Spanish with subtitles, and there will also be a translator. So in the Spanish channel, you can hear English to Spanish, or in the English channel, you can hear Spanish to English. So the presenter is Dr. Rosa Mejia, is the National Advisor for Communicable Diseases and Epidemiological Surveillance for Pan-African Health Organization for Honduras. She receives her master's in epidemiology at the National Autonomous University of Nicaragua and a bachelor's degree from National Autonomous University of Honduras. And she will be addressing us via video, which Adam will just get us started. Thank you, Adam.
Muy buenos días. En primer lugar, quiero agradecer a los organizadores de tan importante evento por invitarme a participar en este panel de discusión. El tema que vamos a tratar el día de ahora es el reforzamiento o fortalecimiento de los servicios de salud. La Organización Mundial de la Salud y la Organización Panamericana de la Salud brindan asistencia técnica a los Estados miembros en el fortalecimiento de los servicios de salud y reconoce el papel central que ejerce la atención primaria en el logro de la salud y el bienestar de la población. También se apoya a los países en identificar áreas prioritarias para mejorar la salud y enfoques específicos para cada contexto basados en conocimientos técnicos, ayudar a formular políticas integrales, crear liderazgos, abordar los determinantes más amplios de la salud, abordajes interprogramáticos e intersectoriales con participación local y comunitaria. En los últimos años, la región de las Américas ha experimentado grandes progresos. Sin embargo, la sobrecarga persiste en los servicios de salud y las desigualdades en materia de salud cada vez son más amplios, lo cual amenaza los logros obtenidos y pone en peligro el progreso hacia un mayor nivel de atención en salud. En Honduras se ha trabajado en el fortalecimiento de los servicios de salud en 3 pilares fundamentales: la atención primaria, la vigilancia y la respuesta. En la atención primaria se han enfocado esfuerzos en lo que es el primer nivel de atención con 3 pilares fundamentales: el fortalecimiento de la infraestructura, capacidades del recurso humano y el equipamiento. En sistemas de vigilancia se ha mejorado en plataformas para poder diseñar informes y boletines de forma oportuna que incluyan los indicadores básicos epidemiológicos, prácticas de vigilancia sólidas y el fortalecimiento de los servicios de laboratorio. El diagnóstico en laboratorio se ha fortalecido para poder tener un tratamiento oportuno y oportunidad a nivel local de un resultado. Estas intervenciones se han logrado con enfoques intersectoriales multidisciplinarios a nivel local. Un ejemplo de ello es el abordaje del dengue. El dengue sigue siendo un problema fuerte de salud pública en estos países de ingreso bajo. Todos los años los países reportan incrementos de casos de dengue y hemos trabajado en el fortalecimiento del primer nivel de atención, que los casos de dengue sean atendidos en el primer nivel y que se haga un seguimiento del manejo clínico y que estos casos no lleguen a saturar los hospitales. También malaria, se ha tenido un abordaje local. Hemos logrado controlar la malaria y tenerla microestratificada a nivel de focos. Se tiene ya estratificado los lugares más endémicos y se hace un abordaje para la detección temprana, el diagnóstico, el tratamiento y una investigación y respuesta de los casos a nivel locales. En el abordaje de las enfermedades desatendidas, el país está trabajando con integrar paquetes en estructuras ya fortalecidas y reconocidas, como es la jornada de vacunación en las Américas, incluido una coordinación en el programa ampliado de inmunización. Se hace administración masiva de medicamentos para las geohelmintiasis. También trabajo comunitario en la vigilancia, en el abordaje de la enfermedad de Chagas. El país ha avanzado y ha eliminado el principal vector Rhonius prolixus y se tiene una intervención a nivel local con tratamiento y diagnóstico de forma oportuna. En lo que concierne a la pandemia de COVID, hemos apoyado al país con esfuerzos para poder tener acciones críticas en respuesta a la pandemia, reorganizando los servicios de salud y planificando el aumento de personal y fuerza laboral para hacer frente a la pandemia, mantener el control y la prevención de infecciones en todos los servicios de salud, optimizar el manejo clínico a lo largo de la atención primaria y garantizar la cadena de suministros. Proteger al personal de salud, tanto en establecimientos del primer nivel y de segundo nivel de atención, como realizar actividades también a nivel comunitario. Desacelerar el contagio. Se ha fortalecido los equipos de respuesta rápida en la detección y aislar los casos, rastrear y poner en cuarentena todos los contactos, mantener una comunicación activa con la comunidad, implementar también medidas de distanciamiento social, fortalecimiento del sistema de vigilancia, fortalecimiento de la capacidad de laboratorio, sistemas de información integrados. En el fortalecimiento de la capacidad laboratorial, el país ha trabajado con tener un diagnóstico más oportuno de los casos para poder tomar decisiones y poder brindar una mejor atención. Actualmente el país cuenta con 4 laboratorios que están trabajando en el diagnóstico de COVID. Eso ha sido un fortalecimiento, ya que la población puede tener una respuesta más rápida y sirve para la toma de decisiones y no saturar los establecimientos de salud. Todavía el país tiene muchas oportunidades de mejora. No ha sido fácil, la pandemia de COVID ha dejado al descubierto los niveles de salud que todavía necesitan fortalecimiento. Por eso las oportunidades en el país en trabajar de manera conjunta es importante reconocerla y poder hacer ese abordaje integrado e intersectorial Todavía es importante difundir y aplicar documentos e instrumentos para actualizar los planes y procedimientos de respuesta y recuperación de manera interdisciplinaria y multisectorial. Trabajo con enfoques integrados, incluyendo la comunidad, equipos de respuesta rápidos integrados y haciendo abordajes locales. También el fortalecimiento del personal de salud. También hay muchos retos que afrontar y que seguir trabajando en el fortalecimiento de los sistemas de salud. La falta de acceso oportuno y asequible a medicamentos esenciales, pruebas de diagnóstico, vacunas, equipamiento, servicios de salud que deben ajustarse rápidamente, sosteniendo y ampliando las capacidades en salud pública y de los cuidados críticos desarrollados para la respuesta de COVID. Falta de recursos humanos es un gran reto que los ministerios de salud están afrontando en el abordaje de la pandemia. Aún así, el seguimiento de las otras enfermedades que día a día saturan los establecimientos de salud. Débil sistema de monitoreo y evaluación, y un reto muy grande que los países afrontan, principalmente en Honduras, es la sostenibilidad que los ministerios de salud deben de dar a estas nuevas capacidades instaladas, como es el diagnóstico de biología molecular en COVID, el fortalecimiento de la gobernanza. Son pilares fundamentales que como organización vamos a seguir trabajando en el fortalecimiento de los sistemas de salud. Y ya para finalizar, el fortalecimiento de los sistemas de salud debe ser un proceso continuo. Seguir manteniendo las capacidades instaladas con un enfoque integrado y sostenido para poder hacer un abordaje integrado en estas enfermedades transmisibles y condiciones relacionadas a poder lograr la cobertura universal de salud en estos países que día a día se enfrentan a retos y problemas muy grandes en salud. La pandemia de COVID es una situación fuerte en estos pueblos donde todavía hay muchas necesidades de seguir. Por tal razón, es importante seguir trabajando en el primer nivel de atención con el fortalecimiento de los sistemas para poder lograr tener una cobertura universal de salud con acceso y cobertura para toda la población involucrada. Muchísimas gracias.
Thank you, Dr. Mejia. I will move to the next speaker, who is Dr. Heather Hack. She is the Chief Medical Officer for Baylor College of Medicine International Pediatrics Aid Initiative at Texas Children's Hospital. Dr. Hack is an assistant professor in pediatrics at Baylor College of Medicine. He also cares for children as a pediatric hospitalist at Texas Children's Hospital. Dr. Hack is highly qualified champion for global health in general. Since early in her career, she receives the undergrad education at McGill University with a major in international development. She completed her master's in health science degree in international public health from Johns Hopkins School of Medicine and her medical degree from the University of Wisconsin Madison School of Medicine and Public Health. She completed her 4-year pediatrics child global health residency at Baylor College of Medicine, including clinical training in Uganda. Dr. Hack has worked in the international public health sector for over a decade. She is a national leader in global health education and promotes best practices to prepare learners from high-income countries for global health experience in low-resource setting. So without any further delay, Dr. Hack, the mic is yours. Thank you. Looking forward.
Great. Okay, let me get into presentation mode. Okay, good morning and good afternoon. Thank you for the kind introduction, Girma. And I'm delighted to be here today to present on implementing health system strengthening building blocks in Uganda. So I want to first say that this talk was originally developed by Dr. Kekitiinwa, who is our executive director and pediatrician with the Baylor College of Medicine Children's Foundation, Uganda. However, Dr. Adi had a family emergency today and was unable to be here. So I'm really honored to present on her behalf. And I am obviously not Dr. Adi, but she's a dear colleague and one of my most influential career mentors. I got to know her well when I was working as a physician in the Baylor, Uganda Pediatric HIV Center of Excellence, and have continued to call her a colleague and friend and mentor ever since. I know Dr. Adi, but I've spent about 6 or 7 years living and working in Uganda and continue to be heavily involved there. So I feel prepared to speak to you about some of the work that Adi is leading in Uganda. So today we're going to do a brief overview of health systems in Uganda and position Baylor, Uganda within that context. And we'll briefly review the health systems building blocks from the WHO, and then review some stories of health system strengthening from Uganda. So Baylor, Uganda is a local NGO in Uganda, founded in 2006 in partnership with the Ministry of Health to implement HIV and reproductive, maternal, newborn, and adolescent health, as well as global health security programs. In addition to running one of the largest pediatric and adolescent HIV centers in the world, serving more than 8,000 patients last year, Baylor, Uganda also partners with the Ministry of Health and multiple district local governments across the country to decentralize HIV services and strengthen health systems. Baylor, Uganda is affiliated with the BIPAI and Texas Children's Global Health Network, which is a network of locally run and independent NGOs across 9 countries across the globe. BIPAI and Texas Children's Global Health Network was originally founded as a pediatric HIV network, but over 20 years has greatly expanded its scope to address multiple service areas, always using a health system strengthening, capacity building, and technical assistance approach. Let's turn briefly to review the health system structure in Uganda, which is comprised of 7 levels based on the level of service they provide and the catchment area that they serve. This starts all the way down at the village health team, or level 1, that provides basic services at the village level, and works its way up through 7 levels using a referral basis to regional and national referral hospitals. Baylor, Uganda works to strengthen the performance and interconnectedness of the 6 health system building blocks identified by the World Health Organization. I don't want to belabor the point because I think a lot of us are familiar with these. But let's briefly review the 6 building blocks, and then I'm going to share stories of how Baylor, Uganda is contributing to all of these areas. So the first building block being service delivery. Second, the health workforce. Third, strengthening information systems. Fourth, working to address essential commodities like medical products, vaccines, and other technologies. 5th, investing in financing. And 6th, leadership and governance. Through strengthening these 6 building blocks in tandem, this increases access, coverage, quality, and safety, and eventually leads to overall improved health, and also responsiveness of the health system, risk protections, and improved efficiency. I would like to highlight that in the time of COVID, I I stress the importance of health system responsiveness and resilience, and I'll show how investments in the 6 building blocks position the health system to be responsive and resilient. So let's hear some stories from Uganda to hear about how Baylor, Uganda is working to address the 6 building blocks of the WHO. First, in terms of improving service delivery, Baylor, Uganda has worked to improve maternal newborn health at local health facilities across the country, really focused on improving service delivery through interventions such as upgrading operating and delivery theaters, training health workers on mentorship, and investing in infrastructure such as solar panels to provide hot water for women and newborns. In terms of the second building block, strengthening the health workforce on the supply side, there's a number of challenges that Baylor, Uganda has worked to address through both short and long-term solutions. To address the low numbers of healthcare workers, Baylor, Uganda is working to support districts to recruit on their terms and pay them, and supporting the districts to absorb these workers. On the challenge of remuneration being low, Baylor, Uganda is working to motivate through continued training, better work environment, and provide work tools, and is also working to continue to advocate for increased health financing to the recommended 17% of GDP. To address suboptimal enabling environments, Baylor, Uganda is supporting the district to have strategic plans and proposals for infrastructure development and increasing funding for capital development. Because some health workers have suboptimal skills, Baylor, Uganda has also been able to train these health workers in leadership and technical skills, and over the long term offer mentorship. In terms of the third building block, strategic information, Baylor, Uganda has worked with individual health facilities across the country to improve messy, inefficient data collection and transform those processes into something that results in easier to use and analyze data. In terms of the fourth health system building block, focused on essential commodities, Baylor, Uganda is working to strengthen the supply chain for reliance. And as an example, working to address drug and essential commodities, they're working to help support a transition to the electronic logistics management information system, improve coordination, address human resource gaps, and integrate management of diseases. In terms of the fifth health system building block around health financing, Baylor, Uganda continues to innovate amidst limited financial resources. So in Uganda, the health expenditure as a share of GDP is 6.5%, significantly below that 17% target. So some examples of innovations that they've brought to address this is reducing workload at the health facility level by improving the community facility linkages and providing better financial oversight of the finances that are available through training of health unit management committees at health facilities. And in terms of the sixth health system building block, improve leadership and governance, I would like to highlight the bottom-up approach that Baylor, Uganda addressed in partnership with the PayPal organization. This approach invested in leadership training to empower and motivate health facility leaders to effectively support health services and equip them with skills for their personal development in the future. At the innovation level, Baylor, Uganda works to believe the health workforce in allowing them to shape and lead innovation to improve health outcomes for their own communities, driving transformative changes and creating ownership. At the collaboration level, Baylor, Uganda brought together various stakeholders and created a space for strategic collaboration, leading to imaginative innovation. So as you can see, Baylor Uganda has made strategic actions to address health building blocks at all levels. And investments in health system strengthening at every building block also builds facile, responsive health systems that are ready to meet emergent unexpected needs like COVID, and to allow the health system to continue to deliver quality and accessible care despite challenges. These investments in health system strengthening also promote resilient and sturdy health systems that can weather the storm. I want to close by sharing a few examples of the responsive and innovative actions that were undertaken rapidly to maintain continuity of HIV care amidst COVID-19 in Uganda. This includes quickly shifting towards decentralized drug dispensing, including home delivery of ARV drugs via Boda Boda, transforming a call center that was mostly focused on providing input to health workers and transforming it into a telephone counseling hotline where patients who are having difficulties accessing drugs or experiencing food insecurity were able to call the hotline for advice. They also were able to focus on online prescriptions to allow contactless drug access to reduce contact, and also shifted into a multi-month dispensing strategy where patients who are stable were able to be given a 6-month supply of drugs to decrease crowding in the facilities and make it easier for patients to access life-sustaining drugs during COVID. So these are just a few examples of how Baylor Uganda was responsive and resilient to provide continuity of care to thousands of people living with HIV during the pandemic. And Dr. Adi would like me to remind everyone that our resilience gives us a reason to smile even in the midst of COVID. Thank you.
Thank you, Heather, for this really nice presentation, and I think giving the examples of what is being done locally and putting them in these building blocks as advised by WHO really gives the learners a good insight into thinking system-wide and putting them in that context. So I think this is really wonderful for us to see and maybe look at the things we do from the same kind of lens and understand in a similar way where we can address issues systematically. So thank you for that. The next presentation is by Dr. Jeff Wilkinson. I've met Dr. Jeff Wilkinson actually in Lilongwe, Malawi, at the place where he works. He is a professor of BGYN and vice chair for global women's health at Baylor College of Medicine. And he's based primarily in Lilongwe for over a decade, I think. He specializes in the care of women with obstetric fistulas, with over 2,500 surgeries performed in Malawi, Tanzania, Sierra Leone, Madagascar, Cameroon, and Haiti. He also developed programs designed to reduce maternal and neonatal mortality and morbidity in low-resource setting. I really seen the place where Dr. Wilkinson works in Lilongwe and met the people he has been working with, and amazing place with which started with so little but has expanded to greatness, and definitely his vision and strengthening the system there and providing the care that's much needed for mothers and children is really amazing. So looking forward to listening to the video recorded message. Thank you.
Oh, hi. I'm Jeff Wilkinson, and here to talk a little bit about public-private partnership development in very low resource settings, the perils, pitfalls, and the persistence needed to make that happen. The Baylor College of Medicine, Texas Children's Hospital maternal and neonatal health programs in Malawi involve work in a community hospital, referral hospitals, the development of a residency program in obstetrics and gynecology, along with our colleagues here, obstetric fistula surgery and research, and a number of innovative projects within those programs, which are cross-cutting across different disciplines and all with a focus on quality of care for the patient. The ultimate goal, besides taking good care of patients and reducing suffering and ending preventable deaths, is to demonstrate what it actually takes financially and programmatically to provide quality of care in a very low resource setting. The hope is that this could be replicated by others in order to provide the same services in those settings. This is a 10-year program built on the experience of a 20-year program, 20-year plus program by the Baylor International Pediatric AIDS Initiative. This requires continuous and daily engagement with our Ministry of Health colleagues at all levels. I see this progression from hubris on the part of myself, others who come to work in this setting, which progresses towards some small amount of knowledge and perhaps occasionally some understanding, multiple failures, and then eventually successes. All projects start out with the goal of sustainability. I've never seen an application for a project in a very low resource setting that didn't wax on about sustainability. I tend to see things in terms of being progressively less unsustainable in a setting where 60% of healthcare dollars come from external sources. Doesn't mean that it won't eventually be sustainable, but in the near term, it will not. And the idea is to have sustainability in your heart and progressively less unsustainable in your mind. Private alone can be the easier way to go. You can set up a small hospital somewhere, pay for it completely externally, but that ultimately almost always fails long term. It ignores the systemic issues that are a part of the system in the country that simply can't be addressed by a private system alone. And often these private initiatives end up being a public-private partnership in the end. Why do we have this goal of demonstrating what it actually takes financially and programmatically to improve quality of care? Inpatient maternal and neonatal care is complicated. It's downright messy. One cannot learn how to deliver the care for 5 to 10% of the women who need intense emergency care safely with a simple emergency obstetrics and neonatal course. Most of this 5 to 10% of cases cannot be anticipated. Maternal and neonatal deaths in Malawi are still at an unacceptable high level. This one just came to visit and wants to be part of the video. Say hi, Maha. Referral centers are overwhelmed with high acuity patients, and you simply need some additional care. Our flagship program at the Area 25 Hospital includes a maternity waiting home, new operating suites, a maternity ward, a permaculture center, and this is all co-managed by the Ministry of Health, the matron, and the in-charge there, collaboratively with Baylor Malawi physician leaders and administrative teams. In the last 5 years, our volume has expanded from 1,800 deliveries a year to 7,000 deliveries a year. Some challenges and opportunities. Money is always a huge challenge. It's undesirable to set a precedent of paying people additional for their work when there's an asymmetry in the pay scales. But clearly, Ministry of Health employees are paid less than the average NGO employee. But in our case, it was unavoidable if we wanted to achieve our goal. You can pay a small amount in order to equalize salaries. For instance, Ministry of Health employees have opportunities to get additional training, go to conferences, go to workshops for which they are compensated, while Baylor Malawi employees are not. So a balance was struck. And this balance, again, was through in-depth conversations with our human resource colleagues at Baylor Malawi and the Ministry of Health. It was a difficult transition. Whenever money becomes in the mix, it becomes difficult. But in the end, we have come upon a system where the average Baylor Malawi employee makes approximately what the average Ministry of Health employee makes when you consider their additional income. Status, or who's your employer, was an issue. Initially, there was a clear, albeit unintentional, division between Baylor Malawi staff and Ministry of Health personnel. That never works when you want accountability and quality of care. It's very difficult to have accountability when you have mixed reporting lines. And whenever accountability is uncertain, quality of care suffers. We transitioned to reporting by all nurses to our Ministry of Health matron and in charge, and then all clinicians report to Baylor Malawi leadership with Ministry of Health assistance. This has worked tremendously well, and now the visitor who comes to the center cannot differentiate between a Ministry of Health employee and a Baylor Malawi employee. But the road getting there was long and difficult. In a country where there had been no precedent for consultant level or attending level physicians to work in a community level hospital, it was a clear and difficult problem to overcome. There was a lot of pushback and resistance to having consultant level physicians at a smaller hospital. But given our volume and complexity of cases, I believe we created a viable justification for this. This was solved again by long and difficult conversations with our Ministry of Health colleagues at all levels, from the top to our local representatives. This went all the way to the Ministry of Health and ultimately was signed off on, and is currently still a challenge, but is being recognized as a necessity given the huge volume of patients that we're seeing. All of these things in a 8-minute talk can't be condensed, but the challenges have been real, and they've been solved by, again, continuous and daily engagement with our Ministry of Health colleagues. This has resulted in a 50% reduction in stillbirths and early neonatal deaths, and a maternal mortality ratio of 14 maternal deaths per 100,000 live births in 2020. This is teamwork, this is persistence, this is staying the course and creating long-term relationships. Thank you very much for listening.
Dr. Wilkinson, this was just an outstanding talk, and definitely gave a lot of exciting information. Definitely something that would make people think about what they do and how they do their global health outreach programs. And I'm sure you'll get probably a few calls or emails from this. So I'll just call the panelists back on the Zoom stage if possible, if everybody can have their mics on. And and videos on. And I know we have one question from the audience for Dr. Mejia. And it's in Spanish, so I'm sorry I can't read that. But Adam, if you can help me with that question, maybe we can start with that, and I may have some additional questions.
Yes, actually, if everyone can switch to the English channel, our translator can translate the question for us.
So what advice or guidance giving to students working in global health if you do not have extensive field experience in performing field work globally is one of the questions. Are there specific fellowships or internships provided particularly by these programs? I assume these programs that were presented today. So any one of the panelists that are on can take this. Any advice for students who want to work in global health and have no experiences?
I could answer that question. I think Baylor is quite ahead of other pediatric surgical centers where they have a fellowship program. So very well structured design program for trainees who wish to take part in global work. Out of that arena, there are a lot of global medical student organizations and trainee organizations that are now working together with their senior mentors, teachers, to get involved in a very constructive way rather than appearing in a visiting center unannounced. So an organization like Incision, which is a medical student organization, is a very good one to join. In terms of training, there's an organization called GASOC, which is trainee-based for surgeons, and they are also very good at placing people in a very controlled environment so that very similarly, you wouldn't expect a trainee from another center to just appear on your doorstep unannounced. So just have it very well structured.
Heather, any thoughts?
Yeah, I can also answer that. So Baylor College of Medicine is a leader in global health education, and we have programming at the medical student and residency and fellowship areas, including really innovative training programs in pediatrics, surgery, and OBGYN. And one thing that I like to encourage learners of global health is to get involved in something that is sustainable and part of a larger partnership, rather than going on these sort of one-off medical mission drop-in type visits. And also during your field experience, to really try to learn about the health system so that you can really understand the context in which local clinical workers are operating and understand challenges at the health system level. And I think those things are going to position you to have a more meaningful engagement in global health and to also understand that broader perspective of health systems issues, which was the focus of today's panel.
Yeah, so thank you to both to that. And you know, some institutions like the University of Wisconsin, for example, they have a global health certificate programs, which really give a good initial starting point together with field experiences that are provided through field courses. And I think all those will really help you develop it. I really agree to Kokila. There are definitely this amazing organizations, actually student organizations that are connected throughout the globe, like Incision, so which can really be the initial entry as well. You know, I just have one additional question that I just wanted to raise. In time of COVID, you know, our global health life has been thrown upside down in so many ways, but I think it has also made us a little bit, you know, maybe better. And maybe there are, you know, are there one or two things, you know, from each of you that you have experienced that is going to continue and you wish you had known this before, kind of, you know, items that you may want to share with that COVID made you understand and help you actually with the work you're doing.
I think if I kick off, what has really shone out, during a crisis, there are opportunities, and the opportunity that I think has been most relevant is the blended learning. A lot of my LMIC colleagues and students and collaborators have said that suddenly there was a literature online which they would have never had access to if it wasn't COVID. So I think that has actually blunted in a wide form. It has just exploded. And a lot of people that have been receiving scholarships from LMICs in the past COVID period found that their access to this kind of material made them more successful than what they would have outside of this.
Are there any thoughts? What one or two things from COVID that really made your global health work stronger and will continue?
Yeah, I can share a few things. One observation that I have is in terms of what sometimes we call reverse innovation and learning from other settings. And I think that we in high-income country settings actually have a lot to learn from health systems in low and middle income countries that tackled COVID in some ways more effectively than we may have. And I think that there's a lot that we can learn from health systems in those settings in terms of how they responded. And then I think there's also a lot of opportunity for multilateral learning. And one of the strengths of the BIPAI network during COVID is I showed you that we're working in 9 countries across the globe, and each of us was able to learn from one another in terms of what the challenges were and share innovations and problem solving to address challenges as they come up. And each country was kind of experiencing different challenges at different times. And so in communicating regularly as a network, we were able to really diffuse innovations and solutions across the network and learn multilaterally.
Yeah, so now great answers. And one thing that I learned is really that I was able to actually recruit a lot more people who otherwise thought that global health means that you have to go and travel, but they were able to actually be part of the team and provide a lot more support and help. And I think this is a time to probably grow that family of global health in general. And Kokila, I really love your thoughts about the public health in surgery. I think we are going somewhere with that, and maybe we will not scare away a lot of people by throwing global surgery there and becoming a little bit too aggressive with that word. And so we have to look at the problem.
Just one more thing. I think that the COVID pandemic has exposed the high income countries in that the low and middle income countries are very good at working at community level and working together and working as a team to control things. We in the high income country didn't do that. And therefore we struggled to control this virus because it was very individualistic, high tech, tertiary level care rather than tackling the problem at a primary care level. And it was a big, huge exposure of the failings of high income countries. And I think the learning curve should switch, where we think we're able to provide answers, but I think the answers are there and we have to learn from them.
So great, I see Jeff just joined us, and I don't know, Jeff, if you were there throughout the discussion, and it was, your video was really outstanding. And you raised really few points, working with policymakers very closely as one of the critical elements. And I just, wonder what kind of strategies, do we all have to have for that internal drain, if you will, so for example, you train, the teachers and all of a sudden Kokila says she goes and they are all gone to the different provinces, or, how transparent do you get even with the finances perspective, Jeff, when you discuss, and, if you can just share about retention and those tough discussions and elaborate a little bit more on it. I don't know if you are.
Hello, everybody. Thanks, Dr. Tefera. I'm afraid my connection is a bit suboptimal. I'm sitting here in the dark without electricity and hopefully some of this is coming through. I think I saw one of the question and answer and heard part of your question, but our strategies largely involve, again, daily communication with our Ministry of Health colleagues and an acceptance in terms of one of the questions is how do we prevent movement of Ministry of Health employees from our particular hospital. Is the answer is that we don't, is that we try to train enough to stay and train enough to go, because that's part of the health system strengthening that we're trying to achieve. And creating the right balance can be quite difficult, because if you lose, at times we've lost half of our Ministry of Health nurses at one time, and that can cause a big dent when 60% of your midwives are Ministry of Health. But I think it's with close communication with the district health officer, you can mitigate some of that while also contributing greatly to the national ability to improve care. So sorry again for my bad communication, and thanks to all the panelists, and especially you, Dr. Tefera. We want to see you back in Malawi sometime soon, and great
Absolutely.
to have you back.
Absolutely. I know we are over time. I don't know if these sessions get cut off at some point, but this is really a great discussion. There is a lot of questions, but I just wanted to entertain one question by Keith Martin that really says, what is there that CUGH can do more of to help out with these partnerships, with the strengthening, the training? Maybe a quick answer before we lose our access. And I'll start with Heather. Just I see you on top of my screen. So Heather, would you start
Sure,
with
yeah.
Scott, and then Kokila, and then maybe Jeff?
Yeah, I mean, I think that, holding forums like this, the CUGH conference, is a great start, just so that we can all learn from one another and hear what the issues are. But I think the pandemic and our shift towards virtual has also taught us a lot about how to use virtual technology to strengthen capacity for global health. So there may be some innovative ways that CUGH can become involved providing virtual assistance, something to think about.
I think my answer to this was long-term partnerships, because they become sustainable and they become friendships and they become lifelong. And you see the progress, because nothing is a quick fix. And it means a two-way learning process for both the institutions. And it stays because it's a sustainable, with not a quick in and going to another place. So my experience with Tanzania is that it's so integrated with the Oxford kind of learning process and our learning process from Tanzania that it has struck a really good balance.
Jeff, any final thoughts from your side? How CUGH could be a little bit more helpful?
I think the CUGH as a great convener could focus on creating the venue for brainstorming collaborative sessions between entities that are having success in different areas, and then cross-disciplinary sessions where we can learn from one another. Going back to COVID a bit, I think one of the strengths of the BIPAI response was that we had different service lines working together to achieve the same goal, whether it was PPE or getting advice on isolation and management of patients. I mean, we had it's the depth and breadth of the program in a way that's fairly unique within the global health community. So
Yeah.
it's
So
a bit vague,
yeah.
but hopefully it's there.
Yeah, so sorry, your voice was coming in and out, but we heard you very clearly, and thank you for making the time in the middle of the night to join us from where you are. And I want to be sensitive about everybody's time, and I really do think the last message, resonates well with me as well. And in fact, we are all in so many different specialties working in relative silos, and I think there is definitely a room for CUGH to be a little bit more of a neutral ground and reconvener of all these different entities or within our healthcare system that we are in isolation struggling, but if we all come together, there is no healthcare system if we don't really see the surgeon, the pediatrician, the internist, the OBGYN, and all that. So I think this might be one of the areas of focus where we may find a common place to discuss and work together, because that is probably the next frontier for all of us. How can we connect with each other and do some, or scale up the work we do? So with that, I know there is really a whole bunch of questions coming, and I don't know if there is going to be, Adam, an offline ongoing answer and question sessions or not, or if we are already on that phase, but I need some guidance about that because I just don't want to undermine the audience. There's over 100 people and there are some questions. So anybody from CUGH or Adam can guide us here?
Yes, we'll do our best to answer the questions following the session.
Okay, perfect.
And I think one forum we can continue to interact is at our booth. So if you do have questions about BIPAI or Texas Children's Global Health, I think there's a way you can interact at our booth.
Perfect. Well, I would really like to thank my panelists and Texas Children's Hospital for organizing this amazing program. And I really say thank you to all of you, and have a great weekend wherever you are. Thank you.